Hello and welcome to the first tutorial in our More Than Skin Deep Anatomy series. My name is Connor, and today we're going to be looking at the bones of the hand. We're going to start by looking at a clinical scenario, then we'll look at the surface anatomy of the hand, the bones and their articulations, and then we'll return to the clinical scenario at the end to help round everything off. Our learning objectives for this session are to recall the key surface structures of the hand and interpret what may lie beneath them, recall the bones of the hand, appreciate the joints and anatomical relationships between the bones of the hand, and be able to relate the bony anatomy of the hand to a novel clinical situation. Let's start by looking at a clinical scenario. This is Tom. He's 18 years old, and he passed his driving test 3 weeks ago. Unfortunately, one night he's out driving, he loses control of his vehicle and he collides with a lamppost. He manages to avoid major injuries, but he's hurt his right wrist, where he was holding the steering wheel, which immediately begins to hurt, and he finds it difficult to move his hand. Pain in particular is worse over his anatomical snuff box. The paramedics attending Tom take him to A&E, where he receives a plain radiograph. The imaging shows that there's displaced fracture of his right scaphoid bone, where he's quickly taken to theatre, and he receives a varial pitched screw fixation. So now let's take a closer look at the anatomy of the hand. So we'll start by looking at the anterior surface of the hand, or the palmar surface, and we'll look at the fingers. So the correct name for our digits are our phalanges. The first phalange being the thumb, the second being the index finger, the third being the middle finger, the fourth being the ring finger, and the fifth the little finger. So we see on the palmar surface of the hand we've got lots of creases. First of which is the distal interphalangeal crease between our distal and intermediate phalanxes. We'll cover those in more detail later. Our proximal interphalangeal crease, our palmar digital crease along the metacarpophalangeal joints, our distal palmar crease, our proximal palmar crease, our thenar crease, and of course our wrist crease. We've also got our thenar eminence and our hypothenar eminence, which are made by the muscular belly sitting deep to the skin. If we look at our hand from a posterior view, we see we've got our finger extensor tendons and our thumb extensor tendons. We've got our knuckles, which are the metacarpal heads, and we've got our anatomical snuff box, bounded by our thumb tendons. There's the two side by side. If you want to pause for a sec and have a think about what structures may lay deep to these surface features, now would be a good time. Looking at the bony anatomy of the hand, at the base of the hand we have this series of irregularly shaped bones called our carpals, which are arranged in two tiers, the bottom which forms the wrist joint, and the top tier forms the joints with the metacarpals. Then of course we have our metacarpal bones, our proximal phalanx, our intermediate phalanx, and our distal phalanx. You'll notice that the thumb only has a proximal and distal phalanx and no intermediate one. To remind you of our surface anatomy, this is where approximately our distal, proximal and palmar digital creases lie. Now we'll take a closer look at the carpal bones. In our proximal most row of these, we have the scaphoid bone, we have the lunate bone, then the triquetral bone. The pisiform bone lies just anterior to the triquetral bone. And on our distal row, we have the trapezium, the trapezioid, the capitate, and the hamate carpal. So we'll look at these carpals in a little bit more detail in a later session. But for the time being, a helpful way to remember these is as some lovers try positions that they cannot handle. The first letter of each word relating to a carpal bone. Now we'll look at the hand from a posterior view. Here's our anatomical snuff box, which we saw is bounded by our thumb extensor tendons. And we'll take a closer look at the carpal bones. So the first thing we'll notice from this side is that our pisiform carpal isn't noticeable, as it's only on the anterior surface of the hand. But naming our carpals again, we have our scaphoid, our lunate, our triquetral, our trapezium, our trapezoid, our capitate, and our hamate carpals. And now I'll give you a chance to look at the carpals from anterior and posterior views side by side. If you want to pause now and see if you can remember the names of these carpals, that'd be a good time to do so. The hand is a great example to look at the different joint types in the body, as we've got 4 different joint types within this one image. The first we'll look at is the saddle joint, in this case the base of thumb joint or the first carpal metacarpal. This acts similarly to a hinge joint in that it allows flexion and extension, but it also allows additional abduction and adduction, which is important for the complex movements the thumb has. Of course, we've got our simple hinge joints, which are our distal interphalangeal, proximal interphalangeal, and thumb interphalangeal joints. These allow flexion and extension, think like your knee. We've got condyloid joints, where in our metacarpophalangeal joints, and our wrist, which isn't labelled here. This acts similarly to a ball and socket joint, but it doesn't allow rotational movements. And finally, we've got gliding or plane joints between our carpals and the base of our metacarpals. These allow very simple sliding movements to occur, but nothing complex. And now I'll let you take a look at the hand bones side by side, in anterior on the left and posterior on the right view. If you want to have a go at naming the bones and the joints, now would be a good time. So now let's go back to the case using our newfound anatomical knowledge. So this mechanism of injury is relatively uncommon for a scaphoid fracture, normally seen following a fall on an outstretched hand. Although when driving you'll notice the wrist is in slight extension and radial deviation, putting strain on the scaphoid, which is in the lower left part of the hand on this image. And this means when a sudden deceleration occurs and the hand is fixed in place, it can lead to a scaphoid fracture. The fracture is almost always central, as the proximal pole is anchored in the wrist joint and the distal pole is anchored in its carpal joints. Something of note with this type of fracture is that blood arriving to the scaphoid comes in a retrograde fashion. This means as it comes from the radial artery, it travels in a distal to proximal fashion. So a central fracture through the centre of the scaphoid interrupts its blood supply and means the proximal segment no longer receives blood. This can lead to something called avascular necrosis, which is where the proximal segment begins to die due to a lack of blood supply, causing osteoarthritis in the wrist joint. This is an X-ray showing a fracture of the scaphoid. The symptoms, as we discussed earlier, are pain, particularly in the anatomical snuff box, especially on palpation. There's pain on the movement of the wrist, as the scaphoid bone is involved in the wrist joint. There's pain on telescoping of the thumb, which is when you press in longitudinal fashion on the thumb. That's because the scaphoid sits approximately in line with the base of the thumb joint. And there's usually limited bruising, which is clinically significant because it makes the diagnosis a little bit more difficult. The treatment for this, in most cases, especially undisplaced scaphoid fractures, is a speaker splint, which just immobilizes the wrist joint and the thumb joint and allows the scaphoid some time to heal on its own. Although in some cases of undisplaced and most cases of displaced fractures, it will require surgical fixation. For example, here using a percutaneous variable pitch screw, which just holds the scaphoid bone in one piece and allows it some time to heal. Here's an X-ray showing a variable pitch screw in place. The outcomes: you must watch for avascular necrosis. This is early signs of osteoarthritis. Non-union is relatively common, hence why these screws are used fairly often. In Tom's case, he recovered well and he's back to driving, albeit a little bit more carefully. Finally, we're going to cover the importance of anatomy and contextualize some of the stuff that we've learned and understand why it's important. So our surface anatomy, of course, is important before you take the X-rays in order to understand what structures might be damaged. So our pain in the anatomical snuff box, of course, leads us to think what lies deep to the anatomical snuff box, in this case, the scaphoid. Our bony anatomy is obviously important to understand the pathophysiology of what's occurred here, and to understand the approaches to the treatment options, such as our screw. The vascular anatomy is important to appreciate the etiology of the consequences, in our case, avascular necrosis. And our joints are, of course, very important to understand what's important to the patient post-operatively, and also the pathophysiology of how a fracture like this occurs, such as the position of our wrist when we're driving. Thank you for listening. There's our references. And if you want to get in contact, try our SurgSoc Anatomy Gmail address. Thank you very much.